Welcome everybody to today's lecture. Today I'm going to be providing an approach to complex, or what are sometimes called mixed acid-base disorders. So the word complex doesn't mean that it's a hard acid-base disorder to diagnose. It usually means that there's more than one acid-base disorder present. So again, going back to what I've talked about previously, when you're diagnosing an acid-base disorder or you want to make the clinical diagnosis, you don't look at the pH, you look at either the total CO2 or the bicarbonate. In general, the total CO2 is made up mostly of bicarbonate, so they give you the same information. And if you find that one or the other are down, remember the bicarbonate's calculated from the blood gas machine from the PCO2 and the pH. The total CO2 is measured directly, but they're both valid and they're both approximately the same number. So if you find that either one is down, you have one of three choices as far as the acid-base cause. It's either a metabolic acidosis, acute respiratory alkalosis, or chronic respiratory alkalosis. And remember that the PCO2 is also down in all three. So the fact that the direction of both the change in bicarbonate and the direction of the change in the PCO2 are both in the down direction doesn't help you. It could be one of the three causes. They all three change the bicarbonate and the PCO2 in the same direction. So the way that we distinguish the three is by looking at the change in PCO2 to change in bicarbonate for each of the three from normality. So we look at what the patient has and we subtract from what we predict the patient would have. And usually we don't have the patient's numbers per se. We have to use population means. And so in metabolic acidosis, for every 10 fall in the bicarbonate, the PCO2 falls by 12. And we call that fall in PCO2 the compensatory response. It occurs after the bicarbonate fell and is due to a change in ventilation. In acute respiratory alkalosis, we also have a decrease in both. Here, the driving cause is the change in the PCO2. If it falls by 10, the bicarbonate will fall by 2. Remember, that's just the bicarbonate buffer reaction. That occurs when you open a bottle of soda that's been carbonated. It has nothing to do with organs, organ physiology in the body. However, if you keep the PCO2 down by the same amount by 10 and wait a number of days, you'll find the bicarbonate's fallen further beyond the 2 so that the total fall, if the PCO2 fell originally by 10, is a total fall of 5. And you can see that these proportions relative to each other are different, and that's what you have to memorize to be able to distinguish these three. So the first thing is, what direction has the bicarbonate changed? And then what is the delta of each of these things? And then plug it into one of the three. So if it's metabolic acidosis, just to reiterate, for every 10 fall in the bicarbonate, the PCO2 falls by 12. So for example, the bicarbonate's 14. In a male, it's normally 24 to start, which is a delta of 10. The PCO2 would have fallen by 12 if it started at 40, which again is a prediction that we're just going by population averages, then it should be 28. So if you see a patient with a bicarb of 14 and a PCO2 of 28, that gives you these proportions or these ratios, and that's compatible with a compensated metabolic acidosis. And you get the same response whether it's anion gap elevated or not. But with respiratory alkalosis, there's a time component. So here in this example, we have a patient with a PCO2 of 40 and we drop it to a new low level. If we follow the bicarbonate, we see that it doesn't just change and stop changing. It actually continues to change over time. This time axis is a bit erroneous. With respiratory alkalosis, it takes about 2 to 3 days, as I'll show, to reach a new steady state, not this number of days. But we call the initial part acute respiratory alkalosis, which again is just the bicarbonate buffer system in your body. But then organ function changes, in particular the kidney, and the bicarbonate falls further until a new steady state is reached. No, we haven't changed the PCO2. We've kept it constant throughout. So we call this phase at the red arrow acute respiratory alkalosis, this initial fall, and we call the final steady state chronic respiratory alkalosis. We do not use the word compensation. We don't call this a compensated respiratory alkalosis. The word compensation is only used with the metabolic acid-base disorders. We divide up respiratory acid-base disorders temporally into acute and chronic. And we don't have a word for what happens in between here. Obviously, this is dynamic, and it's sort of artificial to call just the initial and the end an acid-base name. We don't, for instance, say subacute respiratory alkalosis. So again, for the expected change again, we have a fall in bicarbonate, but now it's due to respiratory alkalosis, not metabolic acidosis. And for every 10 fall in the PCO2, the bicarbonate falls by 2. That's just the bicarbonate buffer reaction. And this is just a proportion. So if the PCO2 fell by 5, this should fall by 1. If the PCO2 fell by 20, this should fall by 4. But if you keep waiting and follow the bicarbonate over time, you'll see that for the same drop in PCO2, there's a further fall in bicarbonate beyond the 2. It falls another 3 due to the kidney. So the total change is 5 for the same 10 fall. And that we call chronic respiratory alkalosis. Now, what if we came to the patient and we're, again, trying to make an acid-base diagnosis and the total CO2 or bicarbonate are elevated? Well, again, you have one of 3 choices. So for each direction, you have 3 choices. And that completes the six clinical simple acid-base disorder. So it's either metabolic alkalosis, or it's acute respiratory acidosis, or chronic respiratory acidosis. And again, the PCO2 is elevated in all 3. So the fact that they're both elevated doesn't help you at all. You have to look at the changes from normality, just like we did in the last slides, but now in the opposite direction. So again, if the bicarb's elevated or the total CO2, it's one of the 3. And we distinguish these 3 not by looking at the pH, but by looking at the delta PCO2 versus delta bicarbonate for each of them. So if the bicarbonate went up by 10, let's say due to vomiting, your PCO2 goes up by 7 from its original level. This we call the compensatory response. People forget that metabolic alkalosis also has a compensatory response. And again, like respiratory alkalosis, we divide respiratory acidosis up temporally into acute and chronic. So again, when you're diagnosing a respiratory acid-base disorder, it's not sufficient if you have the information to say just respiratory acidosis. You also have to have a word prior to that, a temporal word, acute or chronic. So if it's acute, for every 10 increase in the PCO2, the bicarb goes up 1. It goes up a little less than it does in the down direction from the bicarbonate buffer reaction. And in chronic respiratory acidosis, it goes up further due to the kidney. The kidney generates and reclaims the extra bicarbonate, and it goes up another 2.5 roughly, such that the total change is 3.5 above the acute generation. So in metabolic alkalosis, if you're vomiting, if the bicarb went up by 10 from its original level, your ventilation change such that the PCO2 goes up by 7. So for example, if your bicarb's 34, which is an increase in 10, your PCO2 should go up to 47. If you see this, you call this a compensated metabolic alkalosis. And again, it doesn't matter what type of metabolic alkalosis. It could be chloride sensitive or resistant. The ventilatory response is the same. And again, as in the acute respiratory alkalosis, here we have the converse respiratory acidosis, where we raise the PCO2. And again, we find that the bicarbonate over time doesn't stay constant. There's this initial jump due to the bicarbonate buffer reaction, the red arrow that we call acute respiratory acidosis. But if we keep following the patient, even though the PCO2 is not changing any further from its original step change, the bicarb keeps going up and up and up over days if we kept measuring the patient until after 3 to 5 days, we reach a new steady state that we call chronic respiratory acidosis. And that further change is due to a change in renal physiology. So again, if the bicarb goes up acutely, if the PCO2 goes up acutely by 10, the bicarb goes up by 1. That's acute respiratory acidosis. And if you wait longer, it'll go up another 2.5 for the same 10 increase. So the total change is 3.5. Now, the other thing to realize is these changes don't occur immediately. So in metabolic acidosis, when you get the ventilatory response, you don't have a complete response till about half a day to a day later. If you come before that and get the numbers, you're not going to get the complete compensation. The PCO2 won't have gone up as much as you predict. or excuse me, down as much as you predict. And the same is true for metabolic alkalosis, except it takes a bit longer for the PCO2 to reach a new steady state. If you're not waiting long enough, it's not going to look like a simple disorder because the PCO2 won't be what you expect. In chronic respiratory acidosis, it takes 3 to 5 days for the bicarb to go up to its final level. In chronic respiratory alkalosis, it takes 2 to 3 days to fall to its new low level. So you have to be cognizant of these things. Otherwise, you're going to make a mistake of misdiagnosing a mixed disorder, and we'll go into that. So this slide shows all the reasons that you could have what look like complex or mixed disorders. And what this means is that the delta bicarb and delta PCO2 don't fit the numbers that I just showed you. So if you get delta PCO2 and delta bicarbs that don't fit those last 6 rules that I showed, then you have what is called a mixed disorder, or numbers that look like a mixed disorder. Now, these are all the potential causes in medicine why you might get numbers that don't look like a simple acid-base disorder. It could be you're not in a steady state, as I mentioned, that you got the patient before the numbers achieve their new final values and it looks mixed, but it's not. So the first is really not a cause for a mixed disorder. You have a simple disorder that has not reached a steady state yet. We'll talk about how you have to take the delta anion gap and add it to the current bicarbonate. And you have to do that all the time. And I'll tell why. If you find that the bicarbonate value that you get is greater than the normal bicarbonate, that's evidence for a mixed disorder. You could also have normal acid-base numbers, completely normal, but you have clinical causes of more than one acid-base disorders, and you have clues on your electrolytes that there are acid-base disorders present in the non-acid-base numbers like sodium and potassium, even though the acid-base numbers look completely normal. That's something they could give you on an exam. Or you have normal acid-base numbers with an elevated anion gap. That's definitely one they could give you on a test. You could also have lack of appropriate compensation in metabolic acid-base disorders. So if the compensation isn't what I just showed on the previous slide, not what you'd predict, that by definition means that you have a respiratory acid-base disorder in addition. We'll show examples of that. Or you could have lack of appropriate renal responses in chronic respiratory acid-base disorders. For instance, if your patients have CKD or ESRD, you're never going to have numbers that look like chronic respiratory alkalosis or chronic respiratory acidosis that fit perfectly because the kidney can't create the renal response that gives the predicted steady state numbers for your patient's values. So that's only going to occur, that you're only going to have perfect chronic respiratory acid-base disorder numbers if you have normal kidney function. It'll always look less than that, or even in ESRD, it'll always look acute. Or you could have 2 categories of the same metabolic disorder, which I'll show you. So let's give examples of not being in the steady state. So here's a patient with anxiety whose PCO2 is 20 and whose bicarb is 18. And that means that the change in the PCO2 is 20 from its original value, and the change in the bicarb is 6. The question is, do these numbers fit any of the simple acid-base disorders? Well, we have a decrease in the bicarbonate, so it's one of these 3 potential causes. Metabolic acidosis, the delta for each should be 12 for the PCO2 and 10 for the bicarbonate. If it's acute respiratory alkalosis, it should be 10 to 2. If it's chronic respiratory alkalosis, it should be 10 to 5. So in our particular patient, if it was acute, the PCO2 being 20, the bicarbonate should have changed by 4. And in chronic respiratory alkalosis, if the PCO2 fell by 20, the bicarbonate should have fallen by 10. But our patient had a fall in PCO2 of 20 and a bicarb of 6. So this number falls in between these 2 values. And the likely thing is you didn't get the patient long enough after it occurred till this new steady state of 20 to 10 was achieved. So this just shows you the numbers. Acutely, the bicarbonate would have, if the PCO2 fell from 40 to 20, that's a change in 20. Acutely, the bicarbonate would fall by 4, which means if it started, it would be 20. and it would be 14 if it was chronic respiratory alkalosis. Remember, it falls half of what the PCO2 falls. So PCO2 fell by 10. By 20, the bicarb should fall by 10. So we got the patient here in between the two. And that's why the numbers don't fit. So you don't really have a mixed disorder. It just looks mixed because it doesn't fit either acute or chronic. So that's something you always have to be aware of. Here's another example. It's a 18-year-old male who's unconscious and the PCO2 is 80 and the bicarb's 33. That means the PCO2 went up by 40 and the bicarb went up by 9. So the question is, does this fit any of the simple acid-base disorders? So again, we have an increase in bicarbonate, so it's one of these three causes. Could it be metabolic alkalosis? Well, again, the proportion is 10 to 7. With acute respiratory acidosis, it's 10 to 1. And for chronic respiratory acidosis, it's 10 to 3.5. Did either of these fit our patient? Well, our patient's PCO2 changed by 40. So if it was acute respiratory acidosis, the bicarb should go up by 4. Remember, it's 10 to 1. If it's chronic respiratory acidosis, remember it's 10 to 3.5. So PCO2 went up by 40. So the bicarb would go up 4 times 3.5, which is 14. So we should be seeing this if it was chronic respiratory acidosis, that our patient had these numbers. And again, these numbers fall in between. So the most likely cause is that the patient was not in a steady state. We hadn't achieved the appropriate length of time where the bicarb would have gone up by 14. It only had a chance to go to 9 because we came to the patient earlier than the time it takes, which is roughly up to 5 days. So again, the bicarb, let's say, started at 424 and the PCO2 40, and now we raise the patient's PCO2 to 80. What would the time course of the bicarbonates look like in our patient? Well, acutely, in the first few minutes, it would go to 28 because of the bicarbonate buffer reaction. And if we waited long enough, it would be 38. Remember, 10 to 3.5 or 40 in our case to an elevation of 14 from its original level. But we came here in between. So the bicarbonate just had not had a chance to reach its new steady state. So it looked like it wasn't a simple acid-base disorder. But in fact, this was chronic respiratory acidosis, ultimately, that we came too early with before a new steady state was reached. So always be cognizant of the fact that you have to achieve a steady state for the numbers to fit the simple acid-base disorders. Here's another patient with an acute MI. The anion gap is increased 11, so, and the bicarb is 14, so we likely have an anion gap metabolic acidosis. The PCO2 is changed by 5 and the bicarb is changed by 10. Does that, what acid-based, simple acid-based disorder does that fit, if any? So again, the bicarb's down. It's either one of these three. Does it fit metabolic acidosis? Well, for every 10 fall in the bicarbonate, the PCO2 falls by 12. In acute respiratory alkalosis, for every 10 fall in the PCO2, the bicarb chain falls by 2 because of the bicarbonate buffer reaction. In chronic respiratory alkalosis, the bicarb falls further due to the kidneys, so that the total fall in the bicarb is 5. Well, remember that metabolic acidosis takes 11 to 24 hours for the compensation to occur. So in our patient, we had a patient with a PCO2 of 35 and a bicarb of 14. The delta PCO2 was 5 and the delta bicarbonate was 10. If we had waited long enough, with the fall in the bicarb of 14, the PCO2 would have gotten to 28, which would then have given us our simple acid-base rule of a change in 12 to a change in 10. So the reason that the numbers looked like the patient wasn't ventilating properly was because we just came in too early. Patient just got the metabolic acidosis and the ventilation just started kicking in, but it only dropped the PCO2 by 5 to 35 because we hadn't waited half a day to a day. Had we waited longer and followed the blood gases, we would find that the PCO2 would keep dropping until it reached a level of 28. And at that point, we would then say the patient has a compensated metabolic acidosis. So again, not waiting long enough not only affects the respiratory acid-base disorders, but also the metabolic acid-base disorders. So it looks like it's a mixed disorder, but it's actually not. It's a simple acid-base disorder, an anion gap metabolic acidosis, where you didn't wait half a day to a day to achieve the appropriate full compensation. Now, what about this next category where every time you have an elevated anion gap, you have to add the change in the anion gap to the current bicarbonate to get the normal bicarbonate. And the thought there is overly simplistic and has subtleties that probably um, represent the ideal world and not the real clinical world. But the thought is that the change in the anion gap uh, represents the drop in bicarbonate from its original level. In other words, that the anion coming into the system came in with the exact same amount of protons. So you're using the anion gap as a surrogate for the change in proton addition to the body. But there's lots of assumptions that the volume of distribution of the anions and the proton are the same, that they're excreted from the body at the same rate. If in the ideal world the volume of distribution is the same and their input-output handling is the same, then the change in bicarbonate should equal the drop in the bicarbonate from its original level should equal the elevation of the anion gap from its level. And that's why this came about historically, where you look at the change in anion gap and add that to the current bicarbonate to get the original bicarbonate, had you not had the proton load. So if you get an answer that's above normal, that means that you have more than one acid-base disorder, because when you do this, it should end up being just 24 or 23. It should be a normal bicarbonate. If you do this and you end up with a bicarbonate that exceeds normality, you have another acid-base disorder that is tending to elevate the bicarbonate. It just, you don't see it because you have a proton load in addition dropping it. So every time you have an elevated anion gap, always do this calculation. So this is exemplified here. You have a patient with ketoacidosis who's also on Lasix, and here are the numbers. The anion gap is up by 20, up by 23. I'm assuming 12 is the normal anion gap in these cases. You never know for sure, but we'll use that as a normal value. So the delta anion gap's 23 and the bicarbonate's 19. So we have an anion gap metabolic acidosis, and the bicarb fell by 5 and the PCO2 by 6. So this gives you a ratio of 10 to 12. So it's appropriately compensated. But the question is there something else going on in addition to the anion gap metabolic acidosis? And that's why you have to add the anion gap to the current bicarbonate to get the bicarbonate without the acid load, or in other words of saying, what was the original bicarbonate? So when we do that here, if the anion gap changed by 23, we add 23 to 5 and we get 28. And 28 is not normal, which means there was something else raising the bicarbonate in addition to the anion gap metabolic acidosis. And the most likely cause in our patient was Lasix, causing a metabolic alkalosis. So this patient has a mixed acid-base disorder, an anion gap metabolic acidosis, and a metabolic alkalosis. You don't know for sure that the elevation is due to metabolic alkalosis. It could be due to a respiratory acidosis, but that you can't tell usually unless you have clinical causes. And you go by the clinical causes as a clue. Here you have hypokalemia, which would also go along with the Lasix and a metabolic alkalosis. And so that would be the most likely thing on a test. Although when you get this kind of number, it doesn't, it's not synonymous with metabolic alkalosis. You have to think of the 3 acid-base disorders that could be raising the bicarbonate. So in the absence, the teaching point here is in the absence of the anion gap metabolic acidosis, the bicarbonate would have been 28. And you're not going to know that unless you add the delta anion gap to the current bicarbonate. You'll miss that this is a mixed acid-base disorder. You'll think it's just a compensated metabolic acidosis. Now, what about normal numbers with an elevated anion gap? That's another clue that you have a mixed disorder. So here we have a patient with ESRD who's been vomiting and the anion gap is up 8. We look at these numbers and you'd say everything looks normal. And unless you look for other clues, you're going to miss that this could be a mixed acid-base disorder. So there are other clues that the patient's hypokalemic and dysnatremic. So there's something else going on. And when you get these, you typically have an acid-base disorder associated with it. So that should be a clue that you don't have normality. And that could be an exam question also. They'll give you normal numbers. But in fact, remember that normal numbers are only the net result of potentially multiple acid-base disorders that are equal in magnitude but opposite in direction. And they end up giving you normal numbers. So normal numbers does not mean the absence of acid-base disorders. And here you have a clue that you have a metabolic acidosis. You have an elevation of the anion gap, and yet the bicarb's normal. How can that be? There must be something else raising the bicarbonate. Just looking at these numbers without knowing anything tells you that it can't just be an anion gap metabolic acidosis, or this number would be below normality. So you have a number of clues. That's one clue. The fact that you're dysnatremic and hypokalemic also suggests that there's something else going on. And historically, the patient's vomiting. So all those things are compatible with a metabolic alkalosis. So again, we plug everything into this formula. We take the delta anion gap plus the current bicarbonate, and you get an answer here of 33. So you have to account for how could that be 33? And again, given the history of vomiting and the hypokalemia and the dysnatremia, the likeliest thing is metabolic alkalosis raising the bicarbonate to 33 had the patient not had an anion gap metabolic acidosis. You don't know what came first. They're both here simultaneously. All you're doing when you do this is saying, if I wipe out the ESRD effect, what am I left with? It's not that one occurred before the other or after the other. There's no temporal component here. They're both here simultaneously. So again, normal numbers, but you have two acid-base disorders. Now, if the numbers are normal, you know a priori that their magnitude is the same. They're both affecting the bicarbonate to the same extent. One is raising it and one is lowering it, and you end up with a normal bicarbonate because of it. And because the bicarbonate's normal, there's nothing that should drive the ventilatory system. So the PCO2 is also normal. Now, what about normal acid-base numbers with clinical causes of more than one acid-base disorder? That's another cause of mixed or complex disorders. So here's a patient with diarrhea and NG suction. And the anion gap is 10 here. So the anion gap is normal and the patient has normal numbers. So the question is there any acid-base disorder present? Well, we don't have a clue like the last patient that the anion gap is elevated, where if the anion gap's elevated, we know we have an anion gap metabolic acidosis. Here, we have a potential cause of metabolic acidosis, diarrhea, but it's non-gap. So we won't have a clue for that based on the chemistries here. But we do have another clue, and that is the patient's dysnatremic and hypokalemic. And when you see that, even when you have normal numbers, your brain should be thinking, I might have two acid-base disorders here, or three, or four, but a number of them that are equal and opposite in magnitude, leading to normal numbers. So this is an example of a non-gap metabolic acidosis and a metabolic alkalosis due to the NG suction. And the only clue that you have here really is the clinical causes and the fact that you're dysnatremic and hypokalemic. When you get these electrolyte abnormalities, they're almost always associated, especially the potassium changes, they're almost always associated with change in the bicarbonate. So again, another patient with completely normal numbers, but two acid-base disorders that are equal in magnitude but opposite in direction. Here's another example of a 32-year-old female in the third trimester who's been chronically ventilated. She has normal numbers. You know, in the third trimester, she must have a chronic respiratory alkalosis. In fact, it starts occurring in the first trimester. Numbers are pretty much the same when they've been looked at throughout pregnancy. So how could you have a female in the third trimester of pregnancy with normal acid-base numbers should disturb you? And so when you see that, even without knowing anything, and the fact that she's ventilated, you have to think of two respiratory acid-base disorders that are equal in magnitude but opposite in direction, leading to normal numbers. And so this patient has a chronic respiratory alkalosis from pregnancy, and she's on a ventilator, and they're not ventilating her to simulate normal acid-base numbers in pregnancy. They're bringing her to normality. That's a separate question, why they're doing that and whether that's clinically valid or not. But it's because they're keeping her PCO2 at 38. Remember, females have a PCO2 that's not quite 40. It's usually a little bit below, and the bicarbonate's not 25 or 24. It's around 23. So because they brought her PCO2 back to normal, her bicarbonate's going to return to normal. So two chronic respiratory acid-base disorders that are equal in magnitude but opposite in direction. So mixed disorder. Again, another patient with completely normal acid-base numbers, but who has two acid-base disorders. What about the lack of appropriate compensation of metabolic acid-base disorders? So here's a patient with testicular cancer on ifosfamide with a normal anion gap, and the bicarb's 15 and the PCO2 is 25. So that means that the bicarb fell by 9 and the PCO2 fell by 15. What is the diagnosis? So here's our patient with a PCO2 of 25 and a bicarb of 15. Remember that the normal compensation in metabolic acidosis is for every 10 fall in the bicarbonate, the PCO2 should fall by 12. So our patient has a fall in bicarbonate of 9 and the PCO2 fell by 15. The question is, for a fall in 9, what should the PCO2 be? Well, it should be down by 11. Our patient's PCO2 should have been 29 if it was appropriately compensated, right? So the rule is for every 10 fall on the bicarb, this falls by 12. Our patients fell by 9. The math works out that this should have fallen by 11, a little less than 12. So if it started at 40, the PCO2 should be 29. It should not be 25. So here's an example of where the PCO2 fell more than we would have predicted had it been compensated appropriately. But you can't just stop there. So when you have metabolic acidosis or alkalosis, but the respiratory compensation is not what is predicted, right away you have to think of it that means there's an additional respiratory acid-base disorder. So, for example, our patient's bicarbonate is 15, and that's a fall of 9. The expected PCO2 should be down by 11, and it should be 29. So the fact that our patient's PCO2 fell more than that means that the patient has a respiratory alkalosis. So the expected ventilatory compensatory response PCO2 that you predict becomes your new normal. That's the concept. 40 no longer becomes your new normal in these kind of situations. You have to predict what the PCO2 should be based on the fall in the bicarbonate, and that becomes your new norm for a simple acid-base disorder that's compensated. Everything above that becomes abnormal. Everything below that becomes abnormal in the opposite direction. So our patient's PCO2 was 25, and it should be 29. So that is not a compensated metabolic acidosis. It's not a simple acid-base disorder. The patient is ventilating too much. PCO2 is down more than we would predict. And so the patient has a respiratory alkalosis in addition. Now remember, we do not call the compensatory response in metabolic acidosis or alkalosis a respiratory acid-base disorder. We don't call it secondary respiratory alkalosis. We don't use that term. We call it appropriately compensated. In other words, we're saying the ventilation is what it should be, and the PCO2 has fallen 12 for every 10 fall in the bicarbonate. We only use the word respiratory alkalosis or acidosis if the PCO2 is above or below what we predict for appropriate compensation. And you have to know what the appropriate compensation is. Otherwise, you're going to miss the mixed acid-base disorder. If you looked at this patient and said that the bicarb is 15 and the PCO2 is 25, and you call that just a compensated metabolic acidosis, you'd be wrong, because the PCO2 should be 29. That would be what you call a compensated metabolic acidosis in this example. So you must know the acid-base rules to know when you don't have the appropriate compensation so that you can diagnose an additional respiratory acid-base disorder and not miss mixed disorders. So here's another patient, 35-year-old female, suicide attempt with Tylenol, NG suction on a ventilator, and her bicarbonate was 35 and the PCO2 was normal. So what's going on here? Here the delta PCO2 is 0 and the delta bicarbonate is 12. So the patient's PCO2 is 38 and the bicarb is 35. The PCO2 changes 0 from its original level, and the bicarb change is 12. We would expect, if this patient had a metabolic alkalosis from NG suction, that for every 10 increase in the bicarbonate, the PCO2 would have gone up by 7. It wouldn't stay at 38. So if the bicarb went up by 12, the PCO2 should go up by 8. So it went up by 12, assuming the normal female bicarbonate is around 23, and the PCO2 should have gone up by 8, which is the same thing as 7 to 10, 8 to 12. So if her PCO2 started at 38 and it went up by 8, it should be 46. So if this was someone who had a metabolic alkalosis that was compensated, clearly the PCO2 would not have not changed at all, and we would have predicted that it would have gone up to 46. But the patient was on a ventilator, and so they were actually ventilating the patient back to normality, just like the other patient, third trimester pregnancy, rather than decreasing the settings on the ventilator and letting the patient's PCO2 to go to 46, which is what would have happened had she compensated appropriately off the ventilator. So the fact that the PCO2 is not 46, but is in fact normal, means that you must have another respiratory acid-base disorder in addition to the metabolic alkalosis. So again, it's the same concept that the lack of appropriate compensation means that you have a respiratory acid-base disorder in addition. So here, in our example, the patient's bicarbonate's 15, and again, we would have expected the PCO2, oh, sorry, this is in the wrong direction. We would have expected the PCO2 to be 46. And so this is a mistake here. The expected PCO2 is 46. So the fact that it's 38 means that the patient's PCO2 is below what it should be. And remember that this 46 becomes your new norm. So everything above 46 becomes respiratory acidosis, and everything below 46 becomes respiratory alkalosis. So the fact that the patient's PCO2 was 38 means you don't just say she's normal. It should have been 46, which means with the PCO2 of 38, she has a respiratory alkalosis in addition. So this is an important teaching point, that you predict what the PCO2 should be in the metabolic acid-base disorder, and now everything above that becomes what you would now call respiratory acidosis, and everything below that becomes respiratory alkalosis, and that confuses people. They'll say in this example, how can you call someone with a PCO2 of 38 a respiratory alkalosis? And the important conceptual point is it should be 46. If you were normal, it would have been 46. It would not have been 38. And so the fact that it's 38, even though you're used to thinking of that number being normal, when it should be 46, means that the patient's ventilating more than they should be. Here it's due to the ventilator. And so we call that a respiratory alkalosis, because when we use that term, we're not talking about the absolute PCO2. We're talking about what the PCO2 should be for that physiologic state or acid-base disorder. And if you consider the PCO2 normal and don't think about these kind of analysis, you're going to miss the fact that the patient's ventilating too much. You're going to think, oh, everything is normal. They just brought her PCO2 back to 38. But in fact, she has a mixed disorder. She has a metabolic alkalosis from the NG suction, and she has a respiratory alkalosis with a normal PCO2 because of the excessive ventilation. Now, what about the lack of appropriate renal response in chronic respiratory acid-base disorders? Here's a patient with chronic bronchitis, CHF, and Lasix who's got a bicarb of 35 and a PCO2 of 55. And the bicarb went up by 10 and the PCO2 is up by 15. So here's our patient with a bicarb of 34 and a PCO2 of 55. The patient's change in bicarbonate's 10 above normal and the PCO2 is 15 above normal. In chronic respiratory acidosis from COPD, chronic bronchitis, this is the kind of proportion you should get. We would expect that with a PCO2 that's up 15, the bicarb would go up by 5. So the bicarb should be 29. It definitely should not be 34. So we go back to our patient, and there is a reason that it's elevated more than what we predict just from the chronic respiratory acidosis. The patient's on Lasix, which we know is going to cause a metabolic alkalosis. So when we look at these numbers, we have a PCO2 that's driving the bicarbonate up chronically. Both metabolic alkalosis and chronic respiratory or acute respiratory acidosis will elevate the bicarbonate. But for the PCO2 of 55, if it was due to chronic respiratory acidosis, the bicarbonate should have only gone up to 29, given this proportionality for the simple acid-base disorder. But our patient, and we would have expected it to go up by 5 or have a value of 29. In our patient, the bicarbonate's up more than that, which means we have to account for something else raising the bicarbonate other than chronic respiratory acidosis. If you don't know that rule and just look at the numbers, you're going to call this chronic respiratory acidosis, but it's not. The bicarbonate should have gone up to 29, not 34. And so there's an additional acid-base disorder that we have a clinical cause for, and that's metabolic alkalosis, raising it an additional 5. So we have 2 reasons in this patient for the elevated bicarbonate. Another cause of numbers that look mixed or don't follow a simple acid-base rule are 2 categories of the same metabolic disorder. So here we have a female with a pancreatic fistula and ketoacidosis. We look at the anion gap and it's 19. The anion gap is up by about 9. It tends what you call normal. We call 12 normal, will be up by 7. So the anion gap is up by around 7 to 9, and the bicarbonate is 5. So when we look at the delta PCO2 to delta bicarbonate, we have values of 23 and 18. And again, we add the delta bicarbonate, or excuse me, the delta anion gap to the current bicarbonate to get the bicarbonate without the organic acid load. So if we have 7 or 9, whatever you consider the normal anion gap to, in this case, it was taken as 10. If you add 9 to 5, you end up with a bicarbonate of 14. You don't end up with 24, which means the anion gap metabolic acidosis cannot be the only cause of the bicarbonate having fallen, because only a component of that, 7 to 9 of the total drop, can be due to the anion gap metabolic acidosis. If it was the sole cause, then when you added it to the current bicarbonate, you would have gotten 24. The fact that it ends up being lower than 24 means you have something else that's dropping your bicarbonate. So there's more than one cause for the drop in the bicarbonate. And the question is, what could it be? Well, we have a clinical cause here. We have the anion gap metabolic acidosis as a cause, but we also have a patient with a pancreatic fistula, which can also drop the bicarbonate and causes a non-gap metabolic acidosis because of loss of bicarbonate. So that's what was going on here. The anion gap metabolic acidosis can account for a component of it, but the remaining difference is due to the pancreatic fistula. So you have a patient here with more than one cause of a drop in the metabolic acid in the bicarbonate, and therefore you have a mixed disorder. Not that you have a respiratory acid-base disorder, but you have 2 types of metabolic acidosis that are both present simultaneously. And had you not added the delta anion gap to the current bicarbonate, you wouldn't have known you had 2 types of metabolic acidosis. You would have just said this is an anion gap metabolic acidosis. and you would not have thought that the pancreatic fistula might be contributing. It's only once you added the delta anion gap to the current bicarbonate that you have a clue that it alone cannot account for the total decrement in bicarbonate. So you can have two types of metabolic acidosis present, and the only clue that you'll have quantitatively of the contribution of both is by adding the delta anion gap to the present bicarbonate. And again, the thinking is you're getting an answer of what the bicarbonate would have been had you not had the anion gap metabolic acidosis present. And if it's the sole cause, your answer should be 24. If you end up with a number below 24, you have another acid-base mechanism dropping the bicarbonate. Now, it doesn't have to be a non-gap metabolic acidosis. It could be a respiratory alkalosis. Again, that drops the bicarbonate. But in our particular case, you have a clinical cause of why that would be, and we don't really have any other clinical causes of why the patient's ventilation should be excessive. And also you have hypokalemia in the presence of a metabolic alkalosis. So it suggests you have some other renal or extrarenal loss of potassium. The potassium should not be low in the presence of this kind of pH. So that would also be compatible with pancreatic fistula loss or an osmotic diuresis from the elevated blood sugar with the ketoacidosis, which is not shown here. You could also have multiple causes of complex disorders in a single patient. So the causes that I just showed you can occur together. They're not necessarily occurring only independently. So here's a patient with bulimia who's unresponsive with an empty pill bottle. And here is the PCO2 and the bicarbonate. The anion gap is up, assuming it's normally 12, about 30. And the PCO2 is changed by 16 and bicarbonate's changed by 10. Okay, so what is going on here? Well, again, we have an elevated anion gap, so we add that to the current bicarbonate to get the bicarbonate without the acid load, and we end up with a bicarb of 43, not 24. So clearly, there's another acid-base disorder in this patient that's raising the bicarbonate. Now, what else might be going on here? Why do we have a triple acid-base disorder? We have three different acid-base disorders in the same patient. So one clue is this mechanism that I mentioned where you have to add the delta anion gap to the current bicarbonate to get the original bicarbonate. There we see there's something elevated in the bicarbonate. But what clue do we have that there's a respiratory alkalosis also present? And that's because the PCO2 is 22. So the PCO2 22 means that the change in PCO2 to change in bicarbonate is 16 to 10. And remember, in metabolic acidosis that's compensated appropriately, this should have fallen by 12. It should not have fallen by 16. Doesn't matter if there's metabolic alkalosis present or not. It's the final bicarbonate that determines the proportion with the ventilation. Doesn't matter if this changed for 2 or 3 reasons. If it fell to 13, you're going to get the same predicted PCO2 response of 12 to 10. So this patient had a PCO2 fall of 16 for the fall in 10. And that means the PCO2 was 22 and the bicarb 13. Again, 16 to 10. But we know from the simple acid-base rule, it should have been 12 to 10, which means the PCO2 should be 26 if it's a female. Fallen 38 minus 12 is 26. It should not be 22. So the fact that it's 22 means it's below our expected 26. Remember, 26 becomes your new norm, and everything above that is called respiratory acidosis. So if the PCO2 was 30 in this patient, the patient would have a respiratory acidosis. And people say, how can that be? It's not above 40. How can you call 30 a respiratory acidosis? And the point is, the new set point becomes your expected ventilatory response PCO2. And in this case, it should be 26. So everything red is above 26, red being respiratory acidosis. Everything gold should be respiratory alkalosis. So our patient should have been 26, and the patient had PCO2 of 22. So you don't call this just a compensated metabolic acidosis. If you missed that the response was excessive here, you would miss the third acid-base disorder in this patient, and clinically you would have missed that so there's something driving the ventilation. The ventilation is more than it should be. Remember, when you're diagnosing inappropriate ventilatory responses when you're looking at the compensation of metabolic acidosis or alkalosis, you're not just making the Socratic diagnosis of a respiratory acid-base disorder. You're homing in on the ventilation. There's something clinically going on with the patient's lungs or medulla. Something is driving the ventilation that you will miss clinically unless you know uh, what the expected PCO2 should be in your patient and what it actually is. So this patient has three acid-base disorders: an anion gap metabolic acidosis, which we know from the elevated anion gap, a metabolic alkalosis, which we know because when we added the delta gap to the current bicarbonate, we got a very high number of 43, and that's compatible with the patient with bulimia. And we also know that the PCO2 has fallen more than we would predict in a compensated metabolic acidosis, and therefore the patient has a respiratory alkalosis in addition. So the patient has three acid-base disorders, and this patient actually combines two of the causes that I talked about. So again, here's all the categories that you have to think about clinically when you don't have numbers that fit so-called simple acid-base disorders, one of the 6 rules shown in the original slides. It could be that you do have a simple acid-base disorder, but you're just not in the steady state. Remember to add the current bicarbonate to the delta anion gap to see if it's greater. This should be greater or less, actually. It could be less than normal. Normal acid-base numbers with clinical causes of more than one acid-base disorder is something you need to think about. Normal acid-base numbers with an elevated anion gap, that could be on your exam, where the patient's vomiting with ketoacidosis and has normal numbers. Lack of appropriate compensation in a metabolic acid-base disorder, patients with intrinsic kidney disease or ESRD will not compensate appropriately. In this category here, in chronic respiratory acid-base disorders, in this category, the lack of appropriate compensation could be a problem with the ventilation, as we showed. So again, these things are honing you into clinical causes. In this group, it's it's either the lung or the medulla that's the problem. In this group, there's something wrong with the kidney. But again, you have to know what the expected response is in order to home in on the organ and why you're not getting the response predicted. But if you don't, you get by definition another acid-base disorder. And then you could have two categories of the same metabolic disorder. You could have a gap and non-gap type of metabolic alkalosis or acidosis, excuse me, that would drop the bicarbonate. And to know the component of both, you have to add the delta anion gap to the current bicarbonate and see if it's normal or not. If it's below normal, then your non-gap metabolic acidosis is also playing a component. So I think I'll stop there today and take any questions if any of you have things that weren't clear. No
Thank you.
questions?
Thank you.
Okay, everyone. Thanks for joining today, and hopefully approaching mixed acid-base disorders will not be as complicated. You just have to have an approach that you use the same way with every patient, and then it'll become more automatic. At first, it's hard because you've been given different ways to approach these numbers. Remember, the whole thinking behind all of this is not to look at the pH as your initial sort of knee-jerk reaction to assess acid-base disorders. Your knee-jerk reaction should be to look at the delta PCO2 and delta bicarbonate and fit those changes into one of the 6 acid-base disorders and see if it fits one of them. If it's close or fits them perfectly, then that's your diagnosis. If it doesn't fit them, then you have either a mixed disorder or you just didn't wait long enough for the compensation in the simple disorders. Okay, everyone, have a great day.